clinical work what I have done in the past few years. So I've done my MD psychiatry. I have done my fellowship in consultation license psychiatry. So basically, in consultation license psychiatry, we dealt with, or I saw patients who had psychiatric illnesses along with medical illnesses. So be it diabetes, hypertension, HIV, TB, trauma, neurological illnesses. So for 1 year, my fellowship was in patients who had such medical or surgical illnesses. So as an extension of that, I have decided to present on the topic of basically care in terminally ill patients, also known as palliative care. So I hope the screen is visible. Is it visible? Yes. Okay. Yes, thank you. Yes, thank you. So basically, starting with who are the terminally ill? Basically, patients who have chronic debilitating illnesses, life-threatening illnesses. We don't have exact cure for them, or the cure is not with complete remission. As such, so patients who have HIV, AIDS, cancer, as we know, certain types of cancers are treatable, but some of them which become malignant, severe cases, late detected, become life-threatening. Stroke patients who get paralyzed, unable to move on, develop additional medical comorbidities, become dependable, and then again treatment becomes scarce for them. Myocardial infarction or heart attack can result in significant physical dependency. Patient not able to take care, and again becomes as such no cure could be present for that. Heart failure, renal failure, again unless there is organ transplantation, such in certain the diseases, the failure is irreversible. So once we know who are the terminally ill, we go on to talk about palliative care. So before going to palliative care, I want to ask a query to all the audience members who are present today. So what is a good death? So while you ponder on the topic, I'll give you two scenarios. One on the left side you can see is Mr. Ramesh. He was diagnosed with, let's say, lung cancer, which had progressed to brain and bone, and he had received multiple chemotherapy, radiotherapy, and the cancer had progressed to a significant disease, a significant stage, and the doctors had told that there is no cure for per se for now, and patient has few months, few weeks or few months to live. For him, the family members continue to seek treatment. They continue to visit multiple doctors. He continued to receive chemotherapy, multiple radiotherapy, on and off admissions, would come back home, again would be taken to hospitals, ICU admissions. And after a period of 6 months, the patient, Mr. Rakesh, suffered cardiac arrest and desaturation, and he died in an ICU setting where he was all alone. Compared to, let's say, we look at Mrs. Sita, she had initial complaints of breathlessness, swelling in the foot, difficulty, palpitations, not able to walk, and she was diagnosed with cardiac failure. And it was grade 4 cardiac failure, and it was also one of the end stages of illness, and there was no specific treatment. The doctor also gave a similar prognosis to Mrs. Sita, and family members consulted the doctors. They also got to understand that the illness is terminal, and they shifted Mrs. Sita to home. She was taken care of at home. She was provided basic support, life support at home. Weekly or once in 2 weeks, she would be taken to the doctors to see her symptoms, how they are fluctuating, if she is feeling distressed by anything, and medications would be changed accordingly. And Mrs. Sita was, as they had understood that it was the end of her life, multiple family members would come and visit her, go away, grandchildren spent more time, children spent more time with her, and subsequently she passed away after 3 months of the diagnosis. So in these two settings, I want everyone to contrast that Mr. Rakesh survived for around 6 months, whereas Mrs. Sita survived for around 3 months after the diagnosis. And would you say that Mr. Rakesh had a better life or a longer life. Just because he had a longer life, it was a better life compared to 3 months of Mrs. Sita. And in which case, in whose case would you consider that the passing away was a better uh, mm, uh, uh, was a better process altogether for the family members, for the patient himself, herself, in both the cases. So this is something I want everyone to ponder about. Then when we come to talking about palliative care, so basically palliative care is something wherein some people who have uh, uh, terminal illnesses, life-threatening illnesses, where cure is not possible, but this approach of palliative care is focused on care. We don't go about because already the diagnosis has been made, the treatment we know, prognosis we know. We focus on care. We focus on the improving the quality of life of the person. We try to discuss with the patients. We try to make them understand that the illness is there and the dying is a normal process as part of life. We don't try to hasten or postpone death in any of the way, and we try to offer a support system. So this is the whole approach of palliative care. It's patient focused. It's to improve quality of life patient and provide comfort as much as possible in the last duration or the last stage of. So basically, why do we need it? So this is one famous quote from a old Hindi movie Anand, which I like to quote in this presentation always, wherein the protagonist who had a cancer diagnosis, he said that Babu मुझे जिंदगी लंबी होनी चाहिए, जिंदगी बड़ी होनी चाहिए, लंबी नहीं. Basically, he says that life should be large and not long. So this is the goal, that not to just elongate the life, the remaining life of the patient, but to provide quality to that life, to involve the person that what he or she wants to do in that end months. There can be in this what we try to do is we try to involve multiple doctors, multiple specialists, be it surgeons, physicians, anesthetists, psychiatrists, social workers. Apart from that, we try to also involve the family members, because a lot of the time the eventual support is provided by the family members. They have to understand that how to approach this phase of life for the patient, and in the end, once the patient passes away, how to help the family members go through the bereavement process. So open communication, very important with the patient. A lot of the time we would see that, okay, diagnosis is made, the patient family members, they can see if they want treatment, they want to take patient home. There is no discussion. Patient has been diagnosed with a terminal illness, but there is no discussion about as to how the person wants to approach it. So open communication, very important with the patient, with the family members, the treating team. Emotional and spiritual support, a very more than would say the more than the medication support, more than the treatment support. Emotional and spiritual support plays a very vital role in the end stages. How the person is being provided both the emotions, and if person is interested in spiritual support also. So the next question is, when does palliative care start? So if I ask the audience members, when do you think palliative care starts? So as most of us would feel that it's in the end stages, that the illness is not curable now, then let's start the palliative care. Now let us look at what the patient wants. That is not true. The palliative care starts as soon as the diagnosis is made. So if you see in the chart, once the diagnosis is made, definitely the initial part of the treatment is curative. We want to cure or treat the illness. We want to, as much as possible, we want to. So somebody has been diagnosed with, let's say, cancer being the most common one, has been diagnosed with cancer. We want to treat as much as possible. We want to remove the lesion as much as possible, decrease the metastasis, the spread of cancer as much as possible from the body. That is our primary goal, definitely. That is initially, that would be the main chunk of our treatment per se or care per se. But altogether, we also need to start the palliative care. We need to discuss with the patient that, see, the prognosis is like this: 80% survival, 50% survival, 30% survival. We are going through, let's say, chemotherapy, radiotherapy. There is chances you may improve. There are chances maybe you may not improve. So what would you want to do in these stages? Maybe little by little, patient can be, the discussion can start, the communication can start to provide emotional support, to provide as much as possible a place where patient can discuss those things. It should not be that you have provided chemotherapy, you have provided radiotherapy, and suddenly after that patient is being told that it didn't work, you don't have any other hope. So it should not be a sudden breaking of the news to the patient. He or she can be involved in the discussion as early as possible. So that these studies have seen that this helps the person quite a lot. So maybe initially the role of palliative care would not be much. Curative care is more focused on, and as it should be. The illness should be treated as much as possible, and then slowly, as the illness progresses, patient becomes more dependable. The symptoms worsen, illness has spreaded, become worsen, then more and more of palliative care can start. Once palliative care has started, once the illness has progressed too much, patient requires ventilator support, patient requires feeding support, going to bathroom, changing clothes, then the end of life care starts, which is the end part of palliative care. And then palliative care continues even after death. Death of the person happens, because in the throughout the process of palliative care, you had involved the family members. After the death of the person, it's your duty, it's the duty of the palliative team to take care of the family members, how they are coping with the bereavement process. So that is how the process of palliative care goes. So who is involved in the palliative care, or where is it done? So it could be doctors, it could be specialist doctors. Currently, India also has few institutes which trains people in palliative care specifically. Apart from that, a lot of oncologists, lot of anesthesiologists, psychiatrists, surgeons, physicians also work in palliative care. Apart from that, nurses, the nursing staff forms a crucial role in providing care. Apart from that, psychologists, social counselors, lay counselors, support workers, and in the end, family persons, people who want to continue palliative care at home, they are also trained, or they are assisted to take care of the patient at the home. So if you ask where the palliative care is done, is it only at very highly specialized centers, hospital centers? It's not so. You can find them at old age homes, caregiver homes, even at home, personal homes, with the help of aides, training aides, nursing staff. Palliative care is even provided at the at their homes. So in Bangalore, if anybody is interested, these are some of the centers: the Karunashraya Center, Shema Hospice Center, and Fortune Old Age Home Care. If anyone is interested to go and see how the palliative care process is being taken care of, how the approach is as compared to how patients are treated at hospital centers. Now, why specifically older people? Why are they our primary concerns for palliative care? So as we know, people who are in the older age group, they are more vulnerable. They have higher prevalence of degenerative illnesses, dementia, Parkinson's. They are also in a higher range of malignant illnesses, cancer, and so on. They have higher rates of medical comorbidities, diabetes, hypertension, thyroid, stroke, heart-related issues. The complications are more also as the illnesses. If somebody, let's say, has developed diabetes or hypertension at 40 or 50s, then at 60s, 70s, 80s, the long-standing illnesses can cause more complications. So again, more comorbidities make the body more vulnerable to terminal illnesses, and the recovery process, the body's recovery process is not as same as it was in 20 years of age, at 30 years of age. The body slowly starts to become weaker in sense of physical response. Apart from that, people who are at older age are more dependent, require support. Let's say even family support, financial support in some cases, or even physical support as the age increases. Limited social interaction, they become isolated socially. Their friends, family members, parents, some of the known people as they become more, they migrate towards different places, they pass away. For whatever reason, people become more socially isolated, which again predisposes or becomes difficult for them to get proper treatment or get the support as required. Negligence, a lot of time, a very high risk of negligence from the family givers, family caregivers, even from seen that even from the treating team, there is high risk of negligence towards people with older ages. So, what would be the goals of palliative care? Would be to provide comfort, to relieve the distressing symptoms, whatever it be. Most commonly, pain is one of the common symptoms. So, pain relieving medications, breathlessness, sleep disturbances, agitation. Lot of the times, emotional symptoms, depression, anxiety, fearfulness. These things need to be treated as and when they appear. So again, what we are trying to do is we are trying to provide a supportive care. We are trying to provide symptomatic care for this. We are not going towards trying to treat the that would not be the main aim. Yes, the person will still take treatment for, let's say, if he or she has cancer. Yes, the treatment will continue, chemotherapy will continue. But our goal in addition to that will be to relieve whatever other distresses are there to the person, provide support, improve his quality of life as much as possible. In this very important part would be to affirm that he is still alive and to understand that dying is also a normal process in his life. We don't try to hasten death. We don't try to postpone death by any of the means. The palliative care teams understands the psychological and the spiritual aspects of patient care, provides care in as much dimensions as possible, provides a support system, interacts with the family members, what type of care can be provided, what type of visits can be done, where the patient needs care. Sometimes patient themselves or the family members would say that, no, we don't want care at, let's say, old age home. We want to take care of the patient in the home, in our home. So what we do is we try to train the family members, or we try to at least guide them how training how to take care of the patient at home, and if it worsens, when to look for the warning signs, when to bring the patient to the hospital. So those type of support system is provided. A team approach is taken. Team approach meaning that, let's say, patient has pain, then we try to take help of physicians who are specializing in pain relieving medications. If there is breathlessness, there is, let's say, GI issues, diarrhea, constipation, blood is there in stools. So we try to take help of surgeons. If we try to take help of the nursing staff, which play a very huge role when taking care of the person in old age homes, or if trained nursing staff is hired to work in the at home or at any caring facility. Psychologists, support workers, counselors play a major, huge role in discussing various psychological aspects with the patient. What does he or she want? What are the concerns he or she wants to address before passing away? So that is one of the things. Other part which comes after the death of the patient is supporting the family members, which is bereavement counseling. How are they addressing, or how are they coping up with the death of the patient? So some of the myths about palliative care. So I have added few of them. I want the audience member to come up with more myths. We'll have the rounds of we'll have doubts and questions, and we'll discuss about this once the presentation gets over. But I want everyone to come up with more of them. So some of the myths which I have come across is that palliative care means the end of life. That once patient has been started on palliative care, it means that it's the end. That there is no treatment per se now, and then patient is going to die soon. So that is not the case. As I was telling earlier, it starts at the time of diagnosis. It does not mean that the patient once palliative care is started, it means that patient is it's in his or her end stages. It just means that we are also approaching the care from another prospect, from improving the quality prospect also, rather than just treatment. It does not mean that it's at the end stage only. Another myth is palliative care is only for people who have cancer. So that is also not true. that we know that if any life-limiting illness, if any terminal illness which is progressive in nature, can get palliative care. So another is palliative care means no further treatment and death occurs sooner. That is also not true. The treatment continues as usual. If a person is suffering from cancer, we continue chemotherapy, radiotherapy as much as needed. We give additional focus towards the distress, towards the comfortability of patient, what he or she wants, towards the family support. Apart from that, talking about palliative care means no hope in living. So again, what I was trying to tell is that palliative care is not about taking away hope. It is about accepting the illness. It's about nurturing the right kind of hope. Where to focus, what to focus the goals to, what part of life to focus on, how to approach the care of the patient. Palliative care is only provided at hospitals. Again, palliative care is provided by trained specialists at hospital. There can be hospice, old age homes, even at the patient's home. Palliative care can be provided. So to end the presentation, this is a quote by Dame Cicely Saunders, who was one of the founder of palliative care, that she would say that you matter because you are you, and you matter to the last moment of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. So I think that summarizes the quote, or summarizes the true aspect of palliative care, wherein we focus about the patient's quality and care rather than just medically treating the illness. And that is how I would like to end the presentation. We can take up questions, I think, now.
Good evening, Doctor.
Yes.
Good evening. You have explained a very, very true picture of a person particularly affected by cancer. But seniors are having all kind of diseases due to age and other problems, mental worries and other things. But my opinion is there are cases he is living affected by cancer. One nearby a senior person, more than 60, 62 like that. She is living comfortably with her husband. Two sons. One is in abroad, one is in another area. But with the assistant of a lady, maid servant, she is taking food and other things, taking medicines. She has taken treatment at Coimbatore Spas Hospital by referring one of doctor at your department, Dr. P.T. Shivakumar. He has guided the patient and she is living comfortably. In another case, one above 45, 50 years, a rare treatment has been given at Bangalore, but he cannot live. He has succumbed to cancer. These are all two issues we are seeing. But we cannot only about cancer. There are other also, as you observed, one day or other we are going to disappear. Who says? World is a drama stage. All are actors like that. I think Shakespeare. Yes, yes. This is open secret. But we are depending on the physical physician, surgeon, and other, particularly nurses. They are the most attentive for the 24 hours while in inpatient. Even some other advices and other kind words they are giving at the time in the hospitals. Doctors are examining, prescribing, and they are visiting either in outpatients or in inpatients. But the most services we have seen is the staff nurses, qualified staff nurses in great corporate hospitals. Therefore, not only cancer, all diseases, all ages are vulnerable to live in this world. But you have to support positively when patients are approaching. You have to give positive pictures because they want to take some decisions at the end of their stage. They want to take some financial decisions, land matters, and other issues, legal hair issues. All these are at the end of, even in good terms, we have to take some decisions. Now, the extension of life is required to take such decisions. The family members or the close relatives, they have to take care if money is available, if properties are available, or otherwise poor people cannot get these treatments either in government hospital or in private hospitals. They will pray only God. God only they are serving, but they are also living very happily, particularly in rural areas. The medicines, the researchers are day by day increasing. During Corona period, lakhs of people have lost their lives in this, because we don't expect such a wave. Now the people are again coming out of the houses, attending functions and other things. This is my view. You are excellent, but very, very open-minded speeches. Thank you very much, Doctor.
Thank you, sir.
Doctor, this is Jambunathan.
Yes.
Yes, doctor. I mean, you raised the first question about that one patient, Sita, and the other patient. So the universal view perhaps will be Sita will be a better case, because where she has been clearly told. But I mean, I would like to know, doctor, what would be the cost of these palliative care if it is done in various forms? Have you done any study on that? Because that is one important factor that people are worried. People need to take care. One. And second, which is the, you have explained in your PowerPoint presentation that the palliative care starts even at the time of starting the treatment. That is what your, this thing shows. But, is it so, or can it wait? The palliative care, can it wait once, a situation comes where the patient will not have, there are no drugs to treat the patient. Which is the stage and who is taking that decision, doctor? These two are very important things.
Yes, very well put, sir. Very well. One of the two of the common questions which I always get about this. So one is the cost. So luckily in India, the hospice centers, the palliative care centers are mostly NGOs or government started. So the price per se is not very expensive. Yes, there are private palliative centers. Unfortunately, there are not enough government funded or NGO funded palliative centers currently. But I believe that most of them are NGO or government funded. So the price per se is considerably less. The exact amount I'm also not, because it depends on the city, type of city where you're living, how much time, how much care they provide, how much facilities they have, specialists under their organization. So that varies a lot. The second question, which is very, very important, that does palliative care need to start at the time of diagnosis? So again, what I would want to reiterate is that many of the times people believe that once palliative care is started, we'll stop the treatment, that we will not give treatment for the illness. It is not at all so. Palliative care in the beginning will not basically even, it will just try to understand what the person's belief is about the illness. Let's say a person gets diagnosed with cancer. So let's give two case scenarios. One person gets diagnosed with cancer, goes through regular treatment, goes to the oncologist. Oncologist says that, okay, you have, let's say, lung cancer. We'll do the radiotherapy. We'll do the chemotherapy. We'll do 6 cycles. You come after 2 months again. We'll see the process. So this is your normal person who goes to the oncologist, receives treatment, comes after 2 months, improves. The cancer goes into remission. He improves. Second person, let's say, he receives palliative care. So what does he get? So he goes to the oncologist. Oncologist says, yes, you have cancer, you have lung cancer. We'll give you chemotherapy and radiotherapy. We are also referring to the palliative specialist. So what does the palliative specialist do in this case? What additional palliative care does he get? So he goes to the palliative care specialist. The palliative specialist talks to the patient. He asks the patient, so what do you understand the cancer's prognosis is? What do you understand about the illness per se? What do you understand? What would happen if you take chemotherapy, radiotherapy? What would happen after 2 months, let's say 6 months, 1 year? And what are the things you want to do? If the person says, no, I just want to do, I just want to take my chemotherapy, radiotherapy. I want to see how much I improve. I want to wait till 2 months, 6 months. Then, well, that is well and good. That is what will be continued. But in this case, we have addressed the patient's concern also. What he wants to do, she wants to do. Some of the people may want to discuss that, okay, let's say I have 50% chance of survival. I want to discuss the things that what will happen if I don't, if my cancer does not remit. Maybe not now, but 2 months I want to be ready to discuss those things. I have hope. The doctor has hope that I will recover. But these are things which I want to discuss later in life. Some people would not want to discuss. They will say that I will postpone it to the 2 months. So we are providing that option very early in the phase of treatment. It's not that we are going to stop the patient from receiving radiotherapy, chemotherapy. He will continue that care. This is just an extra option we are providing to the patient's perspective to improve his quality of life if he wants to discuss some things with us. So that is what I wanted to clarify in this presentation also, that how palliative care doesn't mean that we are stopping other active treatments, that those continue. This is something in addition we focus to the patient.
Yes, doctor, thank you. See, while going in for palliative care, the patient as well as the patient's relatives, most important relatives, are informed about that and they take an informed decision. And yes, the patient might also feel that I don't like to be, again injured further. Please treat me softly. Yes. So that, in a very easy way, so that I am not exposed to any further this thing. Operations or etc., etc. That kind of an option is provided. Yes, doctor. Thank you very much. And I wanted to add only one thing is that in the palliative list of palliative care homes in Bangalore, you can add St. John's Hospital also. They have a palliative care unit. It's very close to them. In fact, one of my friends' relative was there. Therefore, they have a palliative. And you need to take admission in advance. Yeah. You will have to give treatment, all the details to them in advance. Then they give the place in that palliative home. You have to reserve it. That's the only problem there, because there is huge demand there. That is the only problem. Thank you, doctor. Yes. Thanks for a beautiful presentation.
Thank you.
Hello, sir. I would like to add few things actually. As one of our sir has asked whether palliative care should be at the last end, or as you rightly said, it should be at the beginning. It is a part of the treatment program. And here is like whenever patient comes to us, we say that you take MRI, CT scan, like that. It's a one kind of the service what we provide that focus multidimensionally, not on the disease, but of the patient psychology, sociology, what is he thinking? He may be, as you rightly pointed out, he may be going for chemotherapy and he may be having the doubt in his mind whether this chemotherapy will work or not, whether it will come back, how is the percentage of recurrence. He will be constantly thinking, why does it occur to me only? What are the constant factors? And family is also a little bit, wow, what we are spending this much money, whether it will be helpful for him or not. So these are the common questions which you could not ask to a neurosurgeon or anyone. So the palliative care team is available every time to address these issues. And palliative care is a developing specialty, not only in cancer, but in the chronic neurological conditions like multiple sclerosis, amyotrophic lateral sclerosis, Parkinsonism disease. Since once the condition you got it, it will be there lifelong. You need to continue and you have to live with it. So there comes the role of palliative care actually, and it is not only limited to cancer, it is in the pulmonary also, and there are a lot of branches which are coming up now, and it is an continuous evolving process. And as rightly sir said, it's there in Bangalore also, as well as in Karunashraya is also one of the leading center which is affiliated with WHO, and in Kerala we have Pallium India, which is one of the most premier institute which is set up the guidelines for the palliative care, and it's always developing, and always it is good that the patient are aware of the service. Many people don't know that this service exists actually, and the myths and the thing what you provided, that is a thing which they have to have a clear understanding about it, and that's how they have to go about it. And it was a great presentation. Thank you.
Thank you, Srimanji. I could not have summarized better. Thank you very much.
You are not muted, ma. You are unmute. You have to unmute, ma. Annapurni, you have to unmute. You are muted, ma.
Your voice is not audible.
Yeah, your voice is not audible, ma. You are muted.
Any other questions from the participants? Sir, I would like to ask you a question. Like, can you please throw a light on euthanasia also? What it is?
Yeah, that's very good. Very good.
Okay, so euthanasia for the other audience, if somebody doesn't know, is the part wherein the treating team, or let's say the person in charge of the patient, provides assistance in death to the person. Specifically for India, it is not legal yet. There are certain countries, Switzerland, certain US states, certain European countries, wherein active euthanasia is. So there is two types of euthanasia: active euthanasia and passive euthanasia. Active euthanasia is, let's say, a person says that I want to die. Currently, let's say the person has cancer, and he or she is going multiple cycles of radiotherapy, chemotherapy, lot of side effects, pain, vomiting, headache, not able to take food, sips of water, and he says that I cannot tolerate it further, and I want to pass away. So the person who is in charge provides, let's say, some medications which sedates the patient and stops the respiratory breathing, and the patient passes away in sleep very comfortably. So that is active euthanasia. So let's say there is another person who requires ventilatory support all 24 hours, admitted in ICU, let's say has lung cancer, lungs are not working, is waiting for an organ transplantation, but the list is very long. Let's say metastasis has happened to brain, and continuous support, 24-hour support is required from the ventilation, ICU, and a lot of machines are attached to him. And then the person says, or the family member says, that it's difficult for the patient to continue life as such, and we want you to remove the ventilator or turn off the machines as such. When they call. So once you turn off the machines, the patient passes away as such. So that is passive euthanasia. In India, both euthanasias are not currently legal. So we don't practice. It's an ethical issue wherein so it comes to the point that who decides? Does the patient himself, herself can decide? Does the family members decide? Do the treating team decide? So yes, maybe in some areas, palliative care will also recognize this, will involve this topic. But again, the more important part would be what already is in progress, the communicating with the patient, communicating with the family. That is more important, I would say. And again, the process currently is illegal. We don't practice it as such. But I think a lot of it can be achieved by communicating with the person. What do you want? What does she want? What are the things which are making it problematic for him or her? Can we address those before going to the final step? I think that would be more important.
Thank you, sir.
Intolerance by both patient as well as relatives. That's the main reason to take ventilators, because increasing bills expenditure at the time of admission, they want to do some medical treatment to postpone, not permanently, as you said, but they want to give some support, moral support, financial support. But it cannot go long for a longer period. Then they have to take decisions according to their financial positions. But nobody is interested to kill anybody. They want to extend their loved one. But insurance problem, insurance companies are not giving adequate money as promised. Even and other properties, mortgaging, selling, these are all happening while admitting in corporate hospitals. We are seeing many people worried about treatment as well as financial problems. These things, medical ethics have to be gained by the physicians and other supporting staff according to their family. Even government hospitals are treating like that, because these things are mentally worried, then psychiatric assistance are required, both caretaker and patient. These things, it's all social issues. Why suicides are very, very frequently happening? Because intolerance to pull on with the society, relatives, friends, medicines, cost of medicines. These are all social issues. Then we have to research. We have to research how the senior people can be given good treatment for their because they have served either educated or uneducated. They have served more to societies, to their childrens, to their grandchildrens, to their relatives, to their friends. They are not dead stock. They have toiled like anything. The research should be how long they can be given comfortable life with good medicines, good medical treatment, good counseling, like that. Thank you, Doctor.
Yes, sir. Thank you, sir. Like our doctor is available. Anybody wants to ask any questions? You can please.
As doctor, like you said, this palliative care can be started at an initial stage where the diagnosis is made initially. But as I am aware, most of the hospitals, they don't actually recommend this, or I don't think they have this care in their hospitals or anything like that. They just diagnose initially, and they said the treatment will be starting soon, and that's all. So the patient is, I don't know, especially in the initial stage, the patient will be very fearful, like what will happen to me, what is the stage of my especially this cancer patients or something like that. When they are diagnosed initially, I feel in every hospital, this palliative cares, if it is available there and if they counsel the patients, it will be more recommended. Like,
definitely, ma'am. This is one of the key issues. I just want to ask a question back, ma'am. Why do you think that currently most of the, let's say, I have worked mostly in government hospitals. Why would you say in government hospital this is not being practiced? What do you think is the few reasons or the key?
no, I don't know about the government hospitals, doctor, but in the private also, I had taken one of my relatives to a cancer institute recently where she was diagnosed. But they said, okay, because of your age, we are going to treat you with this and all. So the lady she was very worried, like she didn't know, because the doctors were not forthcoming in telling what the situation was.
Yes.
And we can't read the whatever the reports given. we don't understand most of the reports, like at what stage the disease is or something like that.
Yeah, definitely. So definitely, like one of the key reasons is awareness about palliative care in physicians or practicing physicians, that how much the palliative part also needs to be addressed. Second thing, very importantly, is also palliative care is resource oriented. Like a lot of the time, the resource is not available as much. You don't have training as much in palliative care. You don't have people who have practiced palliative care to provide as much extensive treatment as palliative treatment as from the initial diagnosis per se. The physician also would feel that let's see if the diagnosis, if the person is treated, well and good, we don't need further care after that. So let's start with that rather than discussing those things from the initiating phase. So I would say awareness and resource would be few things which definitely need to be improved to improve palliative care or the process per se in the population.
Yeah, doctor. Adding to that, what I would like to say is basically last 2 decades, if we see the curriculum, actually people who have in the MBBS, palliative care was not a module which everyone was aware of it. But recently, 2-3 years back, it has been made as a curriculum, and the clinicians are made aware about it, and now we can see that not only palliative care specialists but about rheumatologists also. If you see this, the number of rheumatologists is very less, but I think the more people are aware about these branches in their graduation level when they are doing their MBBS, they consider like majority of the major branches are only the specialties they can do. But these are also the branches which they can pursue their career, and how it will be helpful if these people like MBBS doctors are educated at their graduation level. Then their number will increase, and there are number of programs which are happening in and out, and definitely they can help. And according to the madam question what she asked, whether will be burdenful or anything, but as I am aware, these centers which are supported by the WHO, they provide you the free palliative care service actually, where you can just call the numbers which are available free of cost, and whatever query you have, whatever doubt you have, and if they feel like visiting you, they'll come to your home and visit, and they will provide the service, palliative care service, by the multidisciplinary care, ma'am. So I think you can just Google the Pallium India or Karunashraya in Bangalore or some St. John's. I am not aware whether St. John's will provide free service or not, but as I know, Pallium India, which is running a teleconsultation, they can call you, and no need of paying anything. That will be a free consultation, and they will take care on that. And in Bangalore, we have Karunashraya, which is having a free tele helpline. You can call their numbers. Definitely, if they feel that they need to come personally and visit, definitely they'll do it actually.
Thank you, doctor. Thanks a lot.
It's a good additional information.
Yes, sir.
That's a very good additional information. See, whatever.
Yes, sir. Thank you, sir.
Yeah, it was a very good additional information.
Yes, sir. Today, actually, as a part of my social work, I visited one old age home where 22 inmates were there. Like all the inmates were like, I don't know, they were on their no movements, nothing. They were just looked after by one IT professional who had come from Malaysia, and he's looking after them. So when I'm attending this palliative care, I was just thinking whether that person is doing the same thing to those patients. Like he has an in-house doctor, and he's doing free of cost, doctor. So like I was moved by that.
That's good. That's good. That's good.
Where is that center, ma'am?
It's in Vijayanagar, sir. Lavalavike. Today I went and visited the center.
What is the center name, ma'am? What is the center name?
Lavalavike.
Okay, ma'am. Okay.
Yeah. They have got 4 persons. They have made a trust, and they are looking after this terminally ill patients. Like.
Thank you, ma'am. Like I will also like to add upon some points Doctor, what he has spoke early, like he has told, like with MBBS, no, this specialty has to come and it has to be added in the curriculum. Like not only with the MBBS profession, it has also to be added in other professions like psychologist and nursing, because no, the palliative care includes the entire holistic care, which includes inputs from all nursing care and physiotherapists, so mostly the psychologist. So that in future it may, if it is being updated, no, that will be good. I think it will be good in future.
Yes, doctor. Exactly. Because initially the doctor put the question, which is a good death, surrounded by our near ones and dear ones, or dying in a hospital. But as we are becoming very nuclear families, modern families are becoming nuclear families, I think centers of palliative care will increase a lot in India too.
Is any other questions from the audience? Yes, it's time. Shall we end up the session? Yeah. So my heartfelt thanks to Dr. Rahul Patwal, who has spent his precious time in giving a presentation, which is like sensitive topic, which much people will not speak about, but he has came with a unique topic and he has presented to the geriatric population. And thank you very much, sir, for an excellent presentation you have given us. Thank you, sir. I also extend my thanks to all the YouTube and Zoom participants who have just giving support to VMS, and you have just shared your experiences and your queries have been asked. Thank you all for the participation, and I also extend my thanks to our VMS support team, Ms. Lima, and our heartfelt thanks to our HOD, Dr. P.T. Shivakumar sir, and Dr. Vijay sir. And there are some partners. My heartfelt thanks to our VMS partners, that is Government of Karnataka, Bangalore Apartment Federation, Happy 60 Plus, and Spandana Counseling Center, NSC Foundation, REC Foundation, Icon Life Sciences, and Karnataka State Legal Service Authority, and also the Indian Psychiatric Society. So thank you one and all. We have a good session today, and I'm expecting more participants in the next webinar. Thank you all. Thank you so much.
Thank
Have a
you.
good day.
Thanks.
Thank you.
Moderating.
Thank you very much. Thank you.
Thank you.
everyone.
Awareness session.